Welcome to this learning activity on how to score well at the short cases in clinical medicine. Assessment of clinical skills in medicine is carried out in short and long cases components at the final MBBS examination in medicine. In the short case component, candidates' clinical skills are tested in 4 stations, one each in cardiovascular system, respiratory system, nervous system and the abdomen. As the 4 short cases altogether carry 20 marks out of the final 100 marks in medicine, it is important to remember that one short case is worth 5 marks out of the final 100 marks in medicine. At one station, candidate spends 4 to 5 minutes with a given short case, and in about the remaining 2 to 3 minutes, he or she will present findings to the examiners and answer a few questions related to the diagnosis and management of a relevant case. This video would help you to score maximal marks in the short case. It is made to help you first to follow a proper approach in starting the short case examination. 2. To elicit and interpret physical signs detected with correct technique. 3. To present findings detected in an orderly manner. Finally, to answer questions related to the clinical diagnosis of the given short case. This will include video clips where candidates make mistakes in different components of the CVS short case. First, the mistakes done during the approach are highlighted. Next, the mistakes they often do in the general examination, examination of pulses, examination of jugular venous pressure, examination of precordium, and finally, auscultation and presentation of the case are highlighted. An attempt is made to correct those mistakes is given and instructed in these following video clips. Good morning. Can we examine this patient's cardiovascular system? Candidate was asked to examine the patient's cardiovascular system, but he was not sure about the right side of the bed. He first went around the bed to the left side, finally arrived on the right side of the patient. Still, he did not get any consent, introduce himself, or greet the patient. He first exposed the patient without telling what he's going to do. Next, he positioned the patient again without telling what he's going to do. This is a very poor approach to cardiovascular system examination process. Let's look at the correct approach to the cardiovascular system short case examination.
මම අවසානසර වෛද්‍ය ශිෂ්‍යයෙක් ඔයාගේ පපුව පරීක්ෂා කරලා කමක් නැද්ද?
In this instance, candidate first greeted the patient, saying good morning, and he introduced himself as a medical student and explained to the patient that he is going to examine his heart. Then, with the help of the patient, he undressed the patient, and after explaining that he is going to change the bed into correct position, 45 degrees angle was achieved in the examination couch. And these are very important points in the approach to the cardiovascular system examination short case. General examination is a very important component of the cardiovascular system examination, but it has to be relevant and should not be a time-wasting experience. Here are some common mistakes candidates often do in the cardiovascular system general examination, wasting time and showing some irrelevant findings and trying to elicit irrelevant findings. In examining the general examination of the cardiovascular system, it is important to be focused. Here, the candidate checks the patient's temperature, which is again irrelevant. Next, he went on to elicit icterus in the sclera, which has no relevance to cardiovascular system. He examined the patient's fingers for clubbing and used the correct technique, but having not detected clubbing on the first instance, he went on to detailed examination, wasting time. It is important to be aware of the time that you have, the total of 3 minutes. Then he went on to examine ankle edema. Without eliciting it properly, he came back again to examine patient's mouth. Then he went on to examine cervical lymphadenopathy, which has no relevance to cardiovascular system. It is important to be time conscious in this scenario. In this scenario, candidate examined conjunctiva for conjunctival pallow and then went on to look oral mucosa for pallow and any carious teeth. Next, he examined the patient's fingers for finger clubbing and he did it in both hands and didn't waste time. Next, he turned the palmar surfaces to see any abnormalities. Examining for ankle edema, he exerted pressure for a few seconds and look for a depression. And these are important, relevant points in the cardiovascular system general examination. Examination of pulses can yield very important information on the cardiovascular disease. Still, candidates take long time unnecessarily and do not carry out pulse examination properly. Let's look at the common mistakes candidates often make when examining pulses in the cardiovascular system examination. Here, the candidate starts examining the pulses from the right radial pulse. He used the correct technique, but he goes on counting pulses nearly for a minute or so. This is unnecessary, and you have to remember the total time available for the cardiovascular system examination is about 3 to 4 minutes. You have to finish pulse examination maximally within 1 minute. He does examine both pulses, but it should have been done concurrently in both hands. This again is a waste of time. Without checking for radiofemoral delay, he examined femoral pulses on top of the garments. Next, quite unnecessarily, he examined popliteal pulses. Very rarely does this will yield useful findings. This is a time-wasting procedure. He examined peripheral pulses posterior tibial and dorsalis pedis separately in both feet, wasting time on pulse examination. This video will show you a correct approach to examine pulse. Arriving from the right side, he first checked right radial pulse for rate, volume, and rhythm for nearly 15 to 30 seconds. Then he checked for other pulses in the left radial pulse. Having detected high volume pulse perhaps and explaining the patient, he looked for collapsing pulse with the correct technique. To check for carotid pulse, he turned the patient's neck to the left side and checked for cardiac impulse from the other hand. Radial femoral delay was checked with the correct technique. Peripheral pulses were checked together, both posterior tibial and dorsalis pedis. This procedure will save time and it's more focused. A correct approach to estimate jugular venous pressure is very important. And the next video clip will show how candidates make mistakes in this procedure. this instance, candidate is trying to elicit jugular venous pressure in the wrong position. Patient not positioned to 45 degrees. He uses torch to check venous pulsations. Then, quite unnecessarily and quite wrongly, he uses a ruler to measure the elevated jugular venous pressure. Here's a correct approach to examine the elevated jugular venous pressure. It is important to position the head end of the examination couch to 45 degrees angle. Then, patient's head need to be turned to the left side. Candidates try to identify venous and the arterial pulsations of the neck separately. Having identified the venous pulse, he tries to see the elevation of the venous pulsations, exerting some pressure over the right hypochondrium. He gets a rough measure of the elevated jugular venous pressure. This is a correct technique to measure jugular venous pressure. Precordial examination is the next most important component of the CVS examination. And this video will show a correct technique and approach for precordial examination. First, we have to inspect the precordium for any scars, pulsations, or deformities. Next, having seen the apex beat as the outermost position, he located it with a finger and tried to identify whether it is deviated. It is in the 6th intercostal space in the anterior axillary line, a deviated apex. Next, he tried to identify the character of the apex. And finally, look for any other pulsations such as parasternal heave. Cardiac auscultation is perhaps the most important component of the CVS short case, which is done at the end. But it is often the component where candidates base their diagnosis. Here are some common mistakes candidates do in this component. In this instance, candidate using the diaphragm of the stethoscopes auscultate over the cardiac apex for a few seconds, then went on to pulmonary, aortic, and the tricuspid areas in very quick succession. Not enough time to elicit any cardiac murmur, and he did not look for any specific murmur such as mitral stenosis murmur, aortic regurgitation murmur, or mitral regurgitation murmur. This is grossly inadequate auscultation for a CVS short case. This video clip will show you the correct approach to cardiac auscultation. First, candidate using the diaphragm of the stethoscope auscultate over the cardiac apex. He uses adequate time. Next, he uses bell to see any low pitch murmurs. Having detected a diastolic murmur perhaps, he changed the position of the patient to left lateral side and try to hear it better. Next, he looked for any radiation of the murmur over the anterior aspect of the precordium. It is important to use adequate time for cardiac auscultation because it is perhaps the most important component that will give you a diagnosis. He auscultated over the pulmonary area to see any loud pulmonary sound. Next, he auscultated over the base of the heart. In order to elicit aortic regurgitant murmur, it is important to position the patient to a seated position and instruct him to take a deep breath and hold it down, and candidate auscultate for possible early diastolic murmur. Having detected a systolic murmur over the base of the heart, it is important to look for radiation of this murmur over to the neck. Using the bell of the stethoscope, candidates look for radiation of the murmur detected at the base of the heart, perhaps aortic stenosis or sclerosis, into the both sides of the neck. This is important if he detects a murmur at the base of the heart. And this completes the cardiovascular system auscultation. Completing the cardiovascular system examination includes looking for any complications such as heart failure. Here, the lung bases are auscultated with the patient in the seated position to check for any crepitations. Finally, it is important to redress the patient and thank him for the support given during the examination. Having completed the CVS short case, the next step is to present in front of the two examiners. This will take approximately 2 to 3 minutes, and this short clip will show you common mistakes often carried out by the candidates in this presentation. Can you present your findings, please?
I examine this young patient who is not dyspneic and comfortably lying on bed. On his general examination, there's no stenosis, not pale, there's no icteric, there's no lymphadenopathy, there's no clubbing, or there's no ankle edema. On his pulse examination, pulse rate 72 beats per minute and it is regular, high volume, no collapsing pulse. And his jugular venous pressure is not elevated. His apex is not palpable. On auscultation, there's ejection systolic murmur in Bedside mitral area. My probable diagnosis is aortic stenosis.
Candidate committed several mistakes in this presentation. Let me take them one by one. First, a common statement often made by students that lying comfortably on the bed was made. It would have been better to say patient was not dyspneic or orthopneic. Next, he went on to say number of negative findings to start his short case, including no icterus, no lymphadenopathy, which are not relevant to cardiovascular system short case in general examination. Examination of pulses, he said high volume pulse with no collapsing pulse. In the cardiac apex, he mentioned a ejection systolic murmur. It is important to realize that ejection systolic murmurs are elicited at the base of the heart only. And the final diagnosis was the aortic stenosis. When he presented these findings is for something else. Can you present your findings, please?
Cardiovascular system examination of this young patient revealed irregular pulse rate, 110 beats per minute, normal volume, normal character. His cardiac apex is on 5th intercostal space, which is tapping on nature. There's a mid-diastolic murmur best heard in the apex with bell in left-hand position with loud second pulmonary sound. My complete diagnosis is moderate mitral stenosis with pulmonary hypertension complicated with atrial fibrillation. There's no thromboembolic phenomena.
In this instance, candidates makes a better, more appropriate presentation for a cardiovascular short case. He starts without mentioning any negative, irrelevant, long list of no icterus, no lymphadenopathy, no jaundice. He starts from the pulse and complete the pulse with rate, rhythm and character. He is in order: jugular venous pressure followed by the precordial examination. He is detailed on what he heard. He heard a diastolic murmur with the bell, with the patient turned to the left lateral position. Finally, he gives a complete diagnosis such as moderate mitral stenosis complicated with pulmonary hypertension and atrial fibrillation. And this is necessary in a cardiovascular short case to be concise, complete and confident. And this presentation included all such components. The next part of this learning activity consists of several case scenarios. In each case, you will be presented with findings in examination of pulse, jugular venous pressure and precordium in succession. Next, you will be able to hear the heart sounds and any added sounds in the auscultatory component. It would be preferable to use this component with a pair of headphones in order to clearly hear the heart sounds and the murmur. By following these cases, you will be able to get a real-life experience of commonly encountered short cases in cardiovascular system. The cardinal features in isolated mitral stenosis include low or normal volume pulse, which can be irregularly irregular when it is complicated with atrial fibrillation, often elevated jugular venous pressure due to elevated right heart pressure, apex beat not visible or deviated, but the loud first sound can be palpable as a tapping apex. The most Unmistakable component in the diagnosis of mitral stenosis is the mid-diastolic murmur, which is heard with the bell of the stethoscope and the patient turned to the left lateral position. If you hear long enough, the typical pre-systolic accentuation and the low-pitch rumbling mid-diastolic murmur can be clearly heard as in this patient. The most important features in the diagnosis of mitral regurgitation include normal or high volume pulse, which can be irregular, elevated jugular venous pressure. Apex beat in mitral regurgitation is often deviated and is heaving because of the left ventricular dilatation due to the backflow. There can be a thrill if the backflow is severe. The auscultative findings in mitral regurgitation is a typical pan-systolic or long systolic murmur, which is heard with the diaphragm and it radiates to axilla. Sometimes this pan-systolic murmur can be heard all over the precordium, but it is best heard at the apex and radiates to axilla, which is an important feature that you have to learn by auscultating several patients. Combination of mitral stenosis and mitral regurgitation sometimes appear in the cardiovascular system short case. Most useful findings in the examination in these cases include in the pulse, low, normal or high volume pulse depending on the dominant lesion. When the dominant lesion is mitral regurgitation, it can be normal or high volume. When the dominant lesion is mitral stenosis, it can be low volume. It may be irregular, as left atrial enlargement commonly occurs in this case. Jugular venous pressure is often high. Precordial examination in this case reveals a deviated apex, which can be heaving if there is a dominant mitral regurgitation. There can be a systolic thrill based on the severity of the mitral regurgitation. Auscultative findings in combined mitral stenosis and regurgitation include a pan-systolic murmur and a mid-diastolic murmur. In the presence of tachycardia, it may be difficult to differentiate these two murmurs, but if you hear long enough, at least for 30 seconds, you will be able to detect a murmur during systole, which is often pan-systolic, and a diastole, which is mid-diastolic, signifying that there is a combination of mitral stenosis and regurgitation in the given CVS short case. In aortic stenosis, examination of peripheral pulse will reveal low volume radial pulse, which can be felt even in the central carotid pulse. Jugular venous pressure is often normal. Examination of precordium will not reveal deviated apex because it is the left ventricular hypertrophy that occurs subsequent to aortic stenosis, not left ventricular dilatation. Auscultation classically reveals additional sound, a systolic murmur at the base of the heart, which radiates to both sides of the neck. This murmur can be rough or grade 3 to 4 and sometimes heard all over the precordium, but make sure it is best heard at the base of the heart and radiates to neck, signifying left ventricular outflow obstruction due to aortic valve stenosis. In isolated aortic regurgitation, examination of pulse characteristically would reveal high volume and sometimes collapsing pulse. This is revealed even in the peripheral pulses as a femoral thud and corrigan signs in the both carotid pulses. Jugular venous pressure is often normal. The precordial examination will reveal a deviated heaving apex due to left ventricular dilatation. There can be a diastolic thrill at the left sternal edge. The auscultative findings are also best revealed at the left sternal edge, but remember, patient need to be seated and breath held in expiration for you to hear the murmur well. It is an early diastolic murmur which is best heard at the left sternal edge. Sometimes, rarely, a mid-diastolic murmur heard at the apex may occur due to the Austin-Flint effect of the aortic regurgitation, but there is no associated mitral stenosis in this case. In combined aortic stenosis and regurgitation, you will hear and detect a variety of physical signs. in the pulse, the volume can be low or high, or typical bisvariance pulse may be felt in the carotids. Examination of precordium may reveal a deviated apex if the dominant lesion is aortic regurgitation. Auscultation typically would reveal a systolic and a diastolic sound heard at the base of the heart and also at the left sternal edge. Remember, a combination of a systolic murmur at the base of the heart and an early diastolic murmur at the left sternal edge is typically seen in combined aortic stenosis and regurgitation. In atrial septal defect, examination of pulse reveal often low in volume but can be normal. Jugular venous pressure is elevated. Examination of precordium will reveal no apex visible. Apex may be difficult to palpate also, but a palpation may reveal a loud pulmonary second sound. Auscultation is characteristically best elicited in the pulmonary area with a short systolic murmur and a characteristic wide splitting of the second heart sound. This is very important to elicit in ASD, wide split and a systolic murmur at the pulmonary area or at the left sternal edge. The characteristic findings in ventricular septal defect include, in examination of pulse, normal or low volume pulse. Jugular venous pressure may be normal. Examination of precordium may reveal a deviated apex which can sometimes be heaving. The most important findings in ventricular septal defect is sometimes a systolic thrill can be felt over the left sternal edge and a loud pulmonary sound, loud P2, can be felt over the pulmonary area. The murmur heard in ventricular septal defect can be very rough and high pitched if the lesion is small. When the lesion or the defect is large, you may not hear such a loud or high pitched murmur. It can be low pitched but still a pansystolic nature. The murmur in ventricular septal defect can be heard all over the precordium, but it is important to elicit it is best heard at the left sternal edge. This concludes the learning activity on how to score well in cardiovascular system short case. I hope the knowledge gathered in this activity will improve your CVS short case examination in medicine. Thank you.